because I really, really believe this is one of the key topics, not only for clinical hematologists, but for most physicians and people working in, working with patients who present acutely to us. So I'm really excited for that reason, but in particular for the guest speakers we have this afternoon. So before we go on to the introductions, maybe just a few general comments for those who might not have been here before. So this session is a weekly academic or educational event that we organize for people working in clinical hematology or for anyone with an interest in clinical hematology. It's open to everybody, free of charge, and CPD accredited. The talks are also available for watching later. We've got them on a VULA site at UCT. So there's an opportunity for those in training to do some revision. We try to focus specifically on things that are important for trainees, but as you will see, the talks are generally relevant to all of us. Now, today is no exception, and today we're going to speak on massive blood transfusion, as you've seen in the invites. So we've got two speakers this afternoon, Professor Jeannie Callum from Canada, who will be introduced shortly by Matthew Seftel, and Dr. Matthew Gibbs, who I will introduce a little bit later from UCT. And they're going to talk to different aspects of massive transfusion and massive transfusion protocols. So a big welcome from my side to both of you. I can see both of them are in the audience, if I can say it that way already. Thanks for making the time. I'm sure it's very early in the morning, I would imagine, on the west coast of Canada, or wherever in Canada you might be. It's probably much earlier than what it is now, 4 p.m. in the afternoon in South Africa. So a big welcome. Prof. Matthew Seftel is an honorary professor at the University of Cape Town, and I say that first because that's very important to us, but he's also head of hematology oncology in Vancouver, British UBC, University of British Columbia, and also plays a senior role in the blood transfusion service now since recently. So I've asked Matthew, who's made the connection with asking Jeannie to speak today, to introduce Jeannie and her topic, and then we'll take it from there. So Matthew, over to you.
Thank you very much, and good morning or afternoon to everyone, wherever you may be. I hope you can hear me. Do you think I could get a thumbs up from? Okay,
yes, wonderful. We can hear you well.
So thanks for the introduction, Vernon. I'm played a small role in catalyzing a successful invitation for Dr. Callum to speak today. So I've got the honor of introducing her. I think in the nutshell, from a Canadian perspective, Dr. Callum is one of the leaders, if not the leader, in transfusion medicine research and education in this country. And secondarily, she's a leader globally. So I think it's an important and very significant honor to have her at this session today, which is wonderful. Jeannie is a clinical hematologist and transfusion medicine specialist at the Kingston Health Sciences Center, and a professor at the university based there, Queen's University in Kingston, Canada, in pathology and molecular medicine. She recently moved from the Toronto area and still has very significant connections there. She serves as the lead for the Quest Transfusion Research Program at the University of Toronto and is also a professor at the University of Toronto. So Jeannie has major interests in transfusion medicine, including error tracking, blood utilization, management of coagulopathy, especially associated with trauma and surgery. And she's been involved in various ways in multiple large randomized trials that likely you have read and even applied locally. So again, thank you very much for making the time, Jeannie, and a very warm welcome to you.
Thanks very much, Matt, for that kind introduction. I'm delighted to be here today. So I'm just going to share my screen here. Let me know, can you see my screen? Is my audio okay?
Yes, we can.
Yes,
Thank you.
Yes.
All right, so I'm going to talk about massive transfusion protocols and really try and bring the science to what we do and try and change from how we manage a massive bleed from just gestalt to actual evidence. So I get research from Canada, both from Canadian Blood Services, Octapharma, that makes fractionated products, as well as from the military in Canada. So I have 3 key objectives to communicate to you today. The first is to understand that the pathophysiology of the coagulopathy of trauma is super complicated. And because it's super complicated, obviously treating it is obviously complicated. I'm going to go through the trials and the basic science literature behind why we do what we do with a massive hemorrhage protocol, and then key things to remember for every massive bleed patient and going through a case. So what are you treating? Why do we do what we do? And what are the key things that you must provide to your patient? So the first thing that's important to know is, what are we treating? And it's probably highly different patient to patient. We only have a lot of literature on what happens when the patient arrives at the beginning, but obviously that coagulopathy is changing over time, probably making some critical changes even within the first 3 to 6 hours. We call this the acute coagulopathy of trauma shock or shock-induced endotheliopathy. People have multiple different names for it that you'll see when you read review articles.
Mama, stop.
I think we've got somebody not on mute. If you could just mute your line. So this is the first sign that we were changing the way we evaluated the coagulopathy of shock came from this article from Karim Brohi from London in the UK, who looked at 1,000 trauma patients that arrived by helicopter into London. And they found that a quarter of those patients were already coagulopathic before they started pumping in crystalloids and red cells into those patients. So this coagulopathy wasn't something that we were doing to the patients. It was something intrinsic to them, which was a little bit really changed everything and was a major paradigm shift. Having this coagulopathy was associated with much higher mortality rates. About half the patients died. And so this really started this whole basic science investigation into what was happening to a quarter of the trauma patients. And this is extremely important. If your INR rises above 1.2, your mortality starts to go up. Obviously, treating this with, say, fresh frozen plasma probably isn't going to do anything about it, but your INR, when you arrive in the trauma bay, is a major predictor of how you're going to do. I consider it honestly like a vital sign, and I make sure that all the trainees are constantly looking at what's the baseline INR, because it tells you what's going to happen to your patient. So after Karim Brohi's paper, a whole bunch of papers came out, and essentially this is what happens. So the first thing that happens is that the glycocalyx on your endothelial cells degrade. This is very important because it releases about 1 liter in an adult into the, almost like a saline bolus into your patient, but it also exposes thrombomodulin and it releases natural heparins that are in this glycocalyx. This might be great for somebody that's in shock, but it's not so great if you have 8 gunshot wounds to the chest. The second thing that happens is that thrombomodulin distracts thrombin. So instead of thrombin making fibrin, it gets distracted and it starts making an anticoagulant activated protein C. So you go from a situation where we want clotting to a situation where we now have anticoagulation in a bleeding patient. The third thing that happens is that activated protein C that was created by your thrombomodulin cleaves factor 5, and that reduces your thrombin generation. And so it really shuts off your coagulation cascade to further aggravate that bleed. The fourth thing that happens, and probably the most important, is that activated protein C cleaves plasminogen activator inhibitor 1 that really holds on to your tissue plasminogen activator. And so it releases it, so it's out of control. This is no different than giving a stroke patient a bolus of TPA to defibrinate them, or what you would see with a snake bite. This TPA converts plasminogen to plasmin, which results in hyperfibrinolysis. So you break down both fibrin and fibrinogen. So it's taking down both proteins. And remember, fibrinogen is a key protein that's involved in both primary, helping your platelets, and secondary hemostasis. So you're really taking out probably the most important member of the team. And then lastly, what we don't really understand is that the endothelial cells get activated. And we know this because people have looked over time in a trauma patient after admission, and we can see this protein called angiopoietin-2, which is just a marker of endothelial cell activations. So everything's getting revved up. So this is highly complicated. It's not just the coagulation factors are low. There's a whole cascade of things going on that we don't completely understand. So even before resuscitation starts, we have a patient that is now autoheprinized from their glycocalyx. Their thrombomodulin is upregulated. Activated protein C has been released. It's to shut down your coagulation cascade by taking down factor V. You have uncontrolled TPA release, hyperfibrinolysis, and you activated endothelial cells with other coagulation factors maintained. And so this is obviously very different than what we had thought back in 2000 as to what was going on. And this correlates with what's happening clinically. This is a study showing the first thing to hit critical levels. And you can see there, the first thing to tank is that fibrinogen level dropping below 1.5. And so what we see physiologically in patients is matching what we believe is happening pathophysiologically. But I'm not going to talk about what's different in other situations, but this is very different than what you would see in GI bleed. This is a randomized trial called the TRIGGER study, which randomized bleeding GI patients to a liberal transfusion study versus a restrictive. And you can see there almost nobody became coagulopathic and needed platelets, plasma, or cryoprecipitate. And so basically, whatever this coagulopathy of shock and trauma is completely different than what you're seeing in a GI bleed. So how we manage patients has to be individualized by their cause of bleeding. Okay. So now I'm going to transition into that second part is, so what's the science behind the massive hemorrhage protocol? And this is obviously more than just ordering a ratio from your blood bank. It's really more of a holistic approach to trauma. So the goal of a massive hemorrhage protocol is to put into place a protocol to ensure that massively hemorrhaging patients receive state-of-the-art care to achieve the best possible outcomes. They get uniform, high-quality, standardized care. And it doesn't matter who's in the trauma bay that day, who's in the emerge, who's managing that GI bleed. They always get really high-quality care. It's more than an order for a ratio. And so in Canada, we divided this into 7 parts, starting with triggering of this massive hemorrhage protocol all the way through to termination. And so then in between that, we have a whole bunch of steps that we have to achieve. We have to have the right team, they have to be properly trained, we have to be doing the right kind of laboratory testing, we have to make sure that our trauma patients get tranexamic acid, we have to keep that patient warm, we have to make sure we're transfusing them to target until we get our lab results, perhaps giving some sort of base ratio, and then when all the dust settles and we have control of bleeding, they're no longer coagulopathic or they're out of shock, we terminate the protocol so that the blood bank can go back to managing all those other patients. So triggering is a huge problem for physicians. So obviously we have to triage. This is happening in very stressful situations. There are no scores that work very well. And so there's a lot of gestalt and just the gut feeling of the docs at the bedside. And we know that overtransfusion is common. Obviously on one side, under triage could result in a patient dying of hemorrhagic shock. But then over triage is a healthcare delivery problem. It results in people getting overtransfused, blood getting wasted, and techs spending a lot of time managing these patients when they should be managing other patients at the hospital. And so we need some sort of balance between these two. A brilliant systematic review of scores to tell you when to activate your massive hemorrhage protocol was published. And you can see here that there are so many possible scores that you could use. The ones that I like the best are the ones that don't require any kind of blood test result or procedure to be done, because then you can really make your decision earlier. But none of these tools performed any better than anything else. And clinician gestalt was no better than any of these scores. So we're not smart enough in our head to forego this. So somebody needs to do some more work on this to figure out what to use. No score has outperformed something called the shock index, which is super simple. This is your heart rate divided by your blood pressure. Obviously, if your heart rate is 140 and your systolic BP is 50, you're going to have a shock index above 1. And that really predicts who's going to go on to end up undergoing a massive hemorrhage. And so we use probably the shock index. It applies to every possible bleeding patient, and it's simple. And you add that to your, basically, your bedside gestalt. We do know that activating probably pretty quickly is really, really important because of this study that came out of a sub-analysis of the proper study that we're going to talk about in a second. So this was a randomized trial of randomizing patients to 2 different ratios, but when they look back at all of these patients, they found that the time to getting the first pack, that every 1 minute delay to that pack resulted in an increased death rate of 5%. So I think what might be important is how fast we make our decisions and giving us the tools to make very fast decisions. And this speed to the first pack was more important than whether you got 1-to-1 or many other really important factors. So probably we need to figure out how to do this. And so what we teach in Canada is that when you're faced with a bleeding patient, you need to make a decision. Okay, is this a patient that I can just get away with red cells? Is this a GI bleed, a lower GI bleed? They're in hypotensive shock, but I know they're going to stop bleeding pretty quickly and we just need some unmatched red cells. Or is this a patient where we're going to need plasma, platelets, clotting factors, tranexamic acid, and I need the full gambit, and I need to order that massive hemorrhage protocol. In Ontario, where I live, we call that a Coke transfusion, kind of like a Coke stroke. Okay, so triggering is complicated. In terms of the team, we do know that simulations improve the care that we give to patients. And just like tennis or some other sport, you need to practice, you need a coach, you need feedback, and then you get better and better. And we know from systematic reviews that resident performance improves and patient outcomes improve with the application of simulation. And that translates to improved outcomes in both trauma, cardiac arrest, and many other areas. So we can't get away from having to do this team training. Okay, what about testing? So right now on the planet, there are 2 ways to test the patient's coagulation cascade. One is the classic laboratory test that I'm sure you're all familiar with about INR, PTC, fibrinogen, or point of care testing or viscoelastic testing. And this is just one example called a tag, but there are other examples of different devices. We know from application of these in small trials that have been looked at in systematic reviews that they reduce the chance of red cell and plasma transfusion, and they look like they might reduce the death rate from these small randomized controlled trials compared to our standard INR and fibrinogen levels. In cardiac surgery, this has really been proven. This was a step wedge cluster randomized trial that was performed in Canada, which randomized 7,402 patients to regular standard of care compared to viscoelastic testing with these point of care devices. And it reduced the chance of a red cell transfusion, platelet transfusions, and going on to have major bleeding. So certainly in cardiac surgery, there's no question that this performs better than regular clotting factor tests. But when people went to a randomized trial that was very large with this comparing conventional clotting tests compared to this viscoelastic testing, they could find no difference. And this was a negative trial in 400 patients. Although you can see there that the odds ratio right across the board was trending towards the viscoelastic testing, perhaps might be better. And so obviously larger trials are going to be needed. We know from the CRASH-2 study of tranexamic acid, you need about 20,000 patients to look for a 1% difference. And probably it would be in this kind of realm. So probably won't be answered with this kind of trial size, but it gives us at least some preliminary evidence for this in trauma. Okay, the other problem with this is very few hospitals have viscoelastic testing at the bedside because it's complicated and expensive to apply. The other major thing that we know is that having a low fibrinogen in certain situations, both cardiac surgery and postpartum hemorrhage, is really problematic. And if you don't correct it, that patient will not stop bleeding. The first study to highlight this was out of France. This study looked at women that started to have a postpartum hemorrhage, and they looked at their opening first fibrinogen level. And if you were below 2, 100% of those women went on to a severe postpartum hemorrhage. Severe meant they died, they needed hysterectomy, or they needed 4 or more units of blood, or they needed some other intervention. And so we believe in both cardiac surgery and postpartum hemorrhage, we have to get it above 2. Maybe other situations like trauma, maybe 1.5 might be good enough. We did a modified Delphi exercise where we came up with a group of 36 experts, and we came up with what our targets would be based on our laboratory testing. And we settled on, we had to keep the hemoglobin above 80 throughout our resuscitation, that INR below 1.8, fibrinogen above 1.5, but in the fine print, we said in cardiac and postpartum hemorrhage above 2, platelets above 50, and keeping the calcium normal. And that we should be doing testing every hour, or if the patient's bleeding super fast, every 4 red cells that we transfuse. And the standard lab panel should be a CBC, INR, fibrinogen, calcium, potassium, and a PTT at baseline. We don't do PTTs throughout the resuscitation, we just do it at baseline, make sure it's normal or concordant with the INR, and then we go with the INR from that point to save money. Okay, let's talk about tranexamic acid. That is a key component of this protocol. So this comes from the CRASH-2 study, 20,000 patients that were trauma patients randomized to tranexamic acid compared to a placebo infusion, and it reduced the chance of death overall and the death from hemorrhage. It was incredibly effective if you gave it within 1 hour of injury, not 1 hour of arrival, but of injury. And it was pretty cheap, about $500 to save 1 life. And there was no increased risk of arterial or venous thromboembolic complications. This was replicated by the same group out of the UK in the women trial, showing that tranexamic acid reduced the chance of death in women with postpartum hemorrhage without increasing any risks. And when they combined those 2 trials and they looked at what was the benefit over time, every 15 minutes, you lost 10% of the benefit of tranexamic acid out to 3 hours. After that, there was no benefit. So really, you want to get this into the patient within 15 to 60 minutes of the onset of bleeding as a quality metric. One thing that's not well known is that the TXA administration improves the coagulopathy. It corrects your INR and gets you to where you want to get to with your coagulation factors. So this was a study that came out of the US and the UK military, where some patients had been given TXA and other patients not, mainly because the Brits had a policy that all British injured patients would get TXA. Compared to the Americans, they did not give TXA because this was obviously before the CRASH-2 study. And you can see there that overall, for all patients, as well as patients that underwent massive hemorrhage, patients that got TXA, by the time they got to the intensive care unit, had a much better INR and less chance of hypercoagulopathy. This doesn't translate to every possible situation. This was a trial that was done in over 10,000 GI bleeding patients that were having a significant hemorrhage, including people with things like a variceal bleed. And you can see there was no benefit, no matter how you gave it, for what indication, or how sick that patient was. Tranexamic acid doesn't help in a GI bleed, and it increased the chance of thromboembolic complications. So we don't give tranexamic acid to GI bleed. Okay, let's talk about temperature before we go on to the most important section, the transfusion. We don't know a lot about how to manage hypothermia. There aren't very many studies. We know we don't even monitor the temperature in the pre-hospital or the pre-operating room phase. We know that if your temperature is low, your mortality is higher. And we know that for every 1 degree drop in your blood pressure, you increase transfusion rates by about 20%. We know that in the pre-hospital phase, when we do small randomized trials to patients getting almost like an electric blanket versus just regular wool blankets, patients rate their care as better and their temperature goes up. So when you give wool blankets to a patient, it slows down the rate of temperature loss, but they continue to become hypothermic. And so we need to figure this kind of space out and figure out what's going on with the temperature. We did a study at my hospital where we looked at 922 patients that were fortunate enough to at least get to the operating room, and 70% of them were hypothermic. And you can see there, even in the trauma room where we had checklists and we had an exit checklist that required you to do the temperature, only 66% of patients got a temperature check in the trauma room. We're not even checking, and when we check, we don't warn them. We're so focused on everything else. And so basically everybody's temperature goes down to about 35 when they get to the operating room. It stays at 35 in the OR when they start warming, but it takes about 6 to 12 hours to warm them up when they get to the ICU. And they continue to bleed because we do not correct this. Okay, the last section on transfusion. So here's what we have from the literature. So we have the PROPER study, which was a very large study in over 600 patients across North America that were randomized to getting, for every 1 red cell, they got 1 bag of plasma, and then they got 1 pool of platelets, which is about 6 units of platelets, compared to about half of that for the amount of plasma in the other group, and a platelet every other box. And the primary outcome of the study was 24-hour and 30-day mortality. And there was no difference, as you can see there on the left-hand side, there was no difference between this 1-to-1 ratio versus a 2-to-1. That was replicated out of the Harvard group. They looked at before and after implementing a 1-to-1 protocol across their entire hospital, not just for trauma, but for everybody else. And really, there was no benefit across the board for everybody. There was some suggestion in the small number of vascular surgery patients, they might do better with more plasma, but the medicine and surgery bleeds, they did better actually with the lower ratio in terms of mortality. The European guidelines have recommended a ratio of at least 1-to-2, and in Canada, our ratio minimum is that same 1-to-2 ratio. And many people follow this base ratio outside of the United States, where I think more consistently they use the proper 1-to-1, even though it wasn't shown to improve mortality. What's going on right now across the planet is a lot of research on can we replace plasma with concentrates like prothrombin complex concentrates, mainly because they're pathogen inactivated, and then we don't have to worry so much about emerging pathogens, HIV and other viruses in the blood system. And so this is just a small pilot randomized trial that we just completed and published in JAMA Open in April of this year, where we randomized 54 cardiac surgery patients to PCC and 47 to plasma. And you can see there that chest tube output was lower with the concentrate strategy, as well as a reduction in the need for red cells and plasma. And so this is a very interesting, and we've just been funded to do the definitive trial and replicate this in 700 patients. Okay, so I'm gonna finish the talk with a quick case. So this is a 32-year-old man, it's a very Canadian case, who's out riding on his ATM. It's either a Canadian on an ATM or a snowmobile. And he has a rollover and is seen in the emergency department with rib fractures. He's actually discharged with minor injuries, but 3 weeks later, he's driving on the highway and he starts to feel unwell. He calls his wife. His wife happens to be an emergency medicine driver. And she calls 911 and tells him to pull over, finds out where he is, and then he is taken to the local emergency department. When he arrives in the emergency department, he has a heart rate of 130 and a blood pressure of 55. So he has a shock index well above 1, so he's very likely to go on to a massive hemorrhage. And his arrival blood work shows a hemoglobin of 115. 115 is very low on arrival. Most people arrive. So this gentleman's been bleeding for quite some time. His platelet count is low and his INR is high. Because his INR is 1.6, we know that this gentleman has about a 30% chance of death. His fibrinogen is low, so we know he has acute coagulopathy of shock and trauma. And so he's completely defibrinated himself with his release of his own TPA. So I want you to think back over that about the management and how we're going to manage this patient. And so I brought back these 7 things. And so we have a patient who, for sure, we're going to trigger this massive hemorrhage protocol. His shock index is above 1. He's got acute coagulopathy of shock and trauma. He needs all components. We're going to activate the massive hemorrhage protocol to get everybody there. We need this complete team of runners and nurses and interventional radiology activated. We're going to do baseline and then hourly testing. We're going to make sure we include the fibrinogen level because until we get the fibrinogen level into the normal range, this patient's not going to stop bleeding. We're going to give him that crash 2 dose, at least a total dose of 2 grams of tranexamic acid. And we're going to give it one of the first things that we do after our kind of ABCs of our resuscitation. We're going to keep that temperature above 36, and we're going to pay attention to this. Our protocol in Canada, we require everybody to check the temperature at a minimum of every half hour. And then we're going to transfuse them to target. We're going to start with a 2-to-1 ratio until the results of our testing come back. And as soon as we have consistent testing coming back, we're going to switch to laboratory-driven resuscitation so we don't over-transfuse this patient products that they don't need. And we're going to remember to terminate. It's really important to terminate the protocol so the blood bank stops making plasma and other products for your patient, and they clean up what's going on and go back to managing other patients within the hospital. And obviously, definitive bleeding control. This gentleman had a ruptured spleen, so nothing's going to stop any of this problem until we get his spleen out. And so he had an emergency open splenectomy. With that, I'm going to stop talking. I'm happy to take questions after either this talk or the second talk.
Jeannie, thank you so much. Wow, I must say, this was even more than expected. What a fantastic, fantastic talk. We will have more time at the end of the session for questions and answers, but can I hear from the audience, which has just reached record numbers for this meeting, I note. Are there anybody with a question? You can either put it in the chat box or just unmute your microphone and speak up. While we wait, can I ask you, have you found any predisposing factors that predispose some patients to developing this endothelial shock type injury versus others who don't? And in the same vein, do we know whether patients who have underlying thrombophilias or factor V Leiden mutations are to some extent protected, perhaps, compared to those who don't?
Yes, so I'm fascinated by those genetic factors that predispose us to one thing more than the other. What we do know for sure is that people that are unfortunate to be Group O, like me, are more likely to bleed at the time of surgery. Certainly at the time of cardiac surgery, so presumably with trauma as well. If you're factor V Leiden, you have a lower rate of hemorrhage after cardiac surgery. We know going into cardiac surgery, if your fibrinogen just happens to be naturally on the higher end of the bell curve, you're going to have better outcomes. And in trauma, actually, and also in critical care illness, we know that if you're unfortunate to have a mutation in something called your ARAC1 gene, which is kind of a cytokine inflammatory gene. If you're unfortunate to have a particular mutation in that gene, your mortality rate is substantially higher if you're in a traumatic injury. It's unfortunate that that mutation is on the X chromosome. It gives women, obviously, resistance to death during trauma. We've always known that women were more likely to survive a trauma, but now we know that most of that is being driven by that ARAC1 mutation.
Thank you very much for that, Jeannie. Can I Yes, sorry, go ahead. Let me just see who is speaking.
It's Z. It's Z.
Hello, Z.
It's Z.
Yes.
And then, how are you? I've got a very basic question, which I get all the time, which is what evidence or what do we have to support any of the definitions of massive transfusion? Are we talking about 10 units in 24 hours, three red cells in 1 hour, any 4 blood components in 30 minutes, or replacement of 1 blood volume? Which one has got the best evidence supporting it as a definition of massive transfusion?
Yeah, so that's a very controversial topic, and it led the United Kingdom to change our language. So we no longer call it a massive transfusion protocol.
Yeah.
We call it a massive hemorrhage protocol, because that 10 unit definition, I think it's still a great definition. Say if you're going to do a retrospective review of how you're managing major bleeding patients at your hospital, because you can really compare from hospital A to hospital B. If they got 10 units, they're probably similar. That's a great definition for, say, a retrospective review or a quality review or whatever, but it's not going to help you at the bedside managing a patient. And so there's a new definition called a critical activation threshold, which is a certain number of components. It could be, a liter of saline or a red cell or a platelet. And the more that you give within that first 3 hours of resuscitation is way more predictive of inferior outcomes. We recently did a podcast, and one of our emerge docs had a great sort of 5 minutes on how his gestalt around how he makes a decision using first, how much are they taking? And what is their response? What's the trajectory of that patient? If you give the patient 2 red cells and a liter of saline and all of a sudden their blood pressure is completely stabilized, it's the trajectory as well as the amount of products that makes him decide activate, don't activate the massive hemorrhage protocol.
Good. Thanks.
Thanks for that, Jeannie. So let's say you work in a setting where point of care testing is not available, and you want to trigger a massive hemorrhage protocol. What do you think that basic first pack should look like?
Yeah, so we've had a lot of conversations about this, and we in Ontario in Canada, we use the first pack is 4 red cells, and that first pack is really to help you decide what is my patient's response to this, and if the response is very good, all you need is that first pack, and then we prevent that patient from getting plasma they didn't need and all the attendant risks with all those other components and the fluid overload. But if they don't, when you get pack 2, we go on to 4 red cells and 4 FFP. So by the time you finish pack 1 and pack 2, you're now at a 2-to-1 ratio. And we've somehow minimized patients that didn't actually need a massive hemorrhage protocol activation, don't get products they don't need, recognizing we're not good at this. 50% of the time we activate the massive hemorrhage protocol, we shouldn't have done that. But of course we get framed all the time into doing this. And so we use this strategy to minimize the consequences of overactivation.
Thank you very much. I see Cecile, Dr. Cecile Latour has unmuted her microphone. Oh, I think maybe that was by accident. Dr. Anthony Beaton is an anesthesiologist up in the northern parts of the country, Jeannie, and he asks, do you have any comment on the use of fresh frozen plasma in a massive hemorrhage protocol in obstetric bleeding?
Yeah, obstetrical bleeding, in terms of what's happening to the coagulopathy, is a bit of a black box to everybody. In North America, postpartum hemorrhage is exceedingly common. We would experience 3 to 5 major postpartum hemorrhages per year at our institution. And so we could not study them to understand what's happening to the coagulopathy. I think it's very diverse. I think there's probably a difference between someone who has preeclampsia and has like a DIC type phenotype, and then they start to bleed, compared to a woman that has atony and her uterus is just not contracting. Those are very different types of coagulopathy. And so I think we need more research in obstetrical bleeding. because we don't know what we're doing. We don't know if we should give plasma. I think what we do know is that fibrinogen replacement is critical. And wherever we do obstetrics on this planet, we have to somehow figure out how to deliver fibrinogen to these women that are bleeding along with their tranexamic acid. Because I think that that's where the saving these women would come from, along with obviously definitive hemorrhage control with hysterectomy and early aggressive hysterectomy, so that we lose no women to this massive hemorrhage. And certainly African countries are stellar in their performance of rapid hysterectomy, whereas in North America, I call it, we stay and play. Women will get 25, 30 units of blood prior to their hysterectomy, when they should have gotten it before unit 6. And so certainly we have a lot to learn from people in your region about how to do that better. But for plasma, we have no idea what its role is.
Thank you. Are there additional things to think about in the 30 days after a patient has received a massive transfusion?
Yeah, so probably the biggest risk after a massive transfusion for the patients that are fortunate to survive is the acute coagulopathy of trauma switches over to an acute hypercoagulopathy of trauma, and they're at risk of DVT and PE, and we should be less cautious about commencing our anticoagulant therapy in that post period. And then the second thing is a delayed hemolytic transfusion reaction. And that's just forming antibodies. And about 8% of people in that 30 days after a massive hemorrhage will pop up with an antibody, and their bili's going to peak, their hemoglobin's going to drop, and we need to be watching for that.
I must say we've got a lively audience. This is great. David Hauer asks, do children respond in any different way to traumatic bleeding, or can we extrapolate adult data?
Yeah, so we struggled with that when we developed our Canadian type protocol. And we made the decision that we would manage our children exactly the same way, but recognizing certain things about children. They're more prone to the electrolyte abnormalities that we see during a massive hemorrhage. So you need to really be watching their calciums and their potassiums. You need to be watching for the hypothermia. These patients develop just profound hypothermia. And the last thing is, when we do studies in children, they don't die, fortunately. Like, the mortality rate is so tiny. And so any study that we do in children is going to have to be powered to some other outcome. And then just lastly, not withholding tranexamic acid from children when there's really no suggestion that they're higher risk of some complication. And so it's a key part of our protocol. And obviously, you need to do weight-based dosing, and your hemorrhage packs have to look different. And so we have 3 packs for children. We have an adult pack for kids above 12. Then we have a medium pack for those kids between 2 and 12, and then we have an under 2 pack. And the number of red cells and plasma that come in those packs are more appropriate for those children, so that we hopefully prevent them from becoming over or under transfused.
That's brilliant. I think we're going to pause the questions here for a moment. Please keep them coming in the chat box. Just a reminder once again for those who arrived late. Professor Estelle Verberg, who organizes these talks. Thank you again, Estelle, as well, for organizing today's talk and coordinating everything. She will post a link a little bit later where you can just click on it, fill in your details, and then you will be registered for CPD points. So you don't have to put your name and your MP number in the chat box like we did in the past. Great. Now, our next speaker is Dr. Matthew Gibbs, who is a consultant anesthesiologist based full-time at Groote Schuur Hospital, University of Cape Town. We work very closely together on patient blood management, and Matt has got lots of interests, but he's very passionate about things like point-of-care ultrasound, patient blood management, as mentioned, obstetric and transplant anesthesia. He's one of the people in Groote Schuur who can support a liver transplant transfusion free together with his surgical partners. And he's very interested in teaching and training. And he's been tasked by with producing a massive hemorrhage protocol for the hospital. I've not had the good fortune of seeing it yet, so I look forward to your talk, Matthew, and we'd really like to also use this opportunity to discuss and get inputs and hear from Jeannie and anybody else in the audience who's got something to add. So Matthew, welcome. Thank you for agreeing to talk today, and we look forward to listening to you. Over to you.
All right. Good afternoon, everybody, and thank you so much for the invitation to speak to you this afternoon. Thank you, Professor Callum, for a great talk going through some of the nitty-gritty of massive transfusion protocols. And my task here is to see how we can translate much of what we've been talking about into local context. I've been to Canada. I know how cold it is, especially Ontario, and the resources are just in a different league in many ways. But one thing that we do share with Canada is the vast distances between different locations. Now, depending where you are, of course, we're talking about Canada is on a different scale to South Africa. But getting patients to where they need the definitive care that they require is a lot of what we need to sort of plan with our patients. So I've selected to talk a little bit about Saturday night in Cape Town, and that includes both trauma and obstetrics, and I think that's something that we need to be aware of. In terms of my slides, are you just receiving my main slides? You're not seeing my patient notes at all, Bernard?
No, it looks like I think this is your main slide, Matt. Looks
okay,
like it.
Great.
Yeah.
Okay, great. So our initial patient is, which is not unusual. This is from 2 weeks ago. I was on call, the consultant on call, and my senior registrar was dealing with this case in theatre. It's a gentleman who's been shot during an attempted robbery. He was initially stable, but he was peritonitic and required exploratory laparotomy. He had a single gunshot that ended up lodging in his acetabulum and causing a fracture in his pelvis. And he consented to a blood transfusion with a starting hemoglobin of 15.1. He was on table for a very, very long time. Fortunately, they were able to keep him warm. But despite that, he developed some extensive hemorrhage due to an iliac vein injury. He bled out. Subsequently, during the attempt to control the bleeding, he actually developed embolus, or at least thrombosis within the right femoral artery, required an on-table embolectomy. Despite that, he received a large amount of blood products. He managed to, he resuscitated very well and arrived in ICU fairly stable. Unfortunately, he developed compartment syndrome and required a fasciotomy immediately post-op and needed to go back to theatre. He subsequently spent 3 days in ICU and was discharged. Initially, we've got the advantage of being in a tertiary center, which allows us access to point-of-care coagulation testing. This is a take from later on during the day after a few blood products, and as you can see there that his angle was low and his maximum amplitude was both low. So he subsequently received a number of blood products, and we'll go into that now. Now, the entire context of this talk is we need to think about what we are giving, because the fact of the matter is here in South Africa, we're constantly faced with challenges of economics, not only the socioeconomic concerns of our patients who seek care, but our own need to save money. Who do we spend a large amount of money on? Given that the average cost of a red cell concentrate, this is from the latest figures that we have from March this year, 1,500 Rand for a single unit of red blood cells. Similarly for FFP, and then cryoprecipitates and platelets are very expensive, with a single random donor platelet pool of nearly 8,000 Rand. And I'll mention freeze-dried plasma at a later stage, but you can see the relative cost. Now, if we look at this patient who's required this transfusion, the patient received 8 units of packed red cells, 4 FFP, and based on that TEG, we ended up giving some cryo and some platelets with a total cost of about 35,000 Rand. Now, 8 red blood cells is not a massive, it is a large transfusion, but compared to some of my obstetric colleagues who recently transfused 30 units for one patient, as Professor Cullen mentioned, at what stage you need to start thinking about hysterectomy, probably earlier rather than later. And I'm going to mention a case that I've dealt with later on and how we apply different rules. So we constantly have this balancing act that we need to do here in South Africa between the clinical needs of the patients and the fact that we have limited resources. So if we look at, as Anita to start, I'm always interested in the practical applications. We talk about this massive transfusion protocol, but how do you actually get the stuff into the patient? And we are fortunate as a certified trauma center and one of the largest in the Southern Hemisphere. We have certain equipment that allows us to get large amounts of products in that are warmed to an appropriate temperature very rapidly. And here this demonstrates the level 1 transfuser that we use here that uses 2 pressurized chambers that can instantly pressurize to 300 millimeters of mercury. Allows us, if we attach to a large bore cannula or to a sheath in the patient's neck, allows us to put a unit of blood that's warmed to 34 degrees or 36 degrees within around about 3 to 4 minutes. Because of this heat exchanger, we're able to warm the patient's blood from cold to warm and in the patient within a few minutes. And it makes a massive difference. Cell salvage is, I think, an important aspect that we have access to at this tertiary center. But we need to just think about the issues of where else can we apply cell salvage, if not at a tertiary center. And here we just have a clip of how rapidly the flow rate of level 1 actually achieves. So in terms of the burden of disease, we've got a population of at least 60 million by now, and we've got 3 sort of major levels of dealing with maternal health. We've got non-communicable diseases as well as HIV/AIDS and tuberculosis, and then the effects of violence and trauma. And many of these health challenges require blood transfusions as part of their management. If we break it down into just looking at the trauma burden, this is a hospital about 50 kilometers away from us called Westphalia. This is the reflection of just one calendar month. They saw over 3,000 cases, of which 17% are trauma cases, and most of them actually over the weekend. A high proportion of road traffic accidents, but also a lot of blunt assault, stabs, gunshot wounds, which are associated with increased blood loss. And this high trauma caseload is much higher than that of comparable centers, say in Malawi or Botswana, Kenya and Rwanda. And this has got a high economic cost, both direct and indirect. And obviously, I'll look now at the costs involved. But in terms of indirects, the fact of the matter that a lot of these patients are 18 to 34, they're male, and they are breadwinners. And if they're either in hospital or, in fact, have a prolonged stay in hospital, this means a decreased income. So, another center in Helderberg, which is around about 70 kilometers from Cape Town, again, about 24% of their cases were trauma-related. They saw over 14,000 patients within 4 months, and their intentional trauma rate is close to 45%, which is a similar sort of level, and just reflects the high level of interpersonal trauma we experience here in South Africa. And that's reflected in many of our centers within South Africa. At Grooteskier, we have one of the largest trauma referral hospitals in the world, with an annual caseload in a trauma center alone of around 12,000 cases. The rate of violent interpersonal injury is extremely high, with a high amount of cases involved in alcohol implicated. And as you can see, looking at the table on the right-hand side, you can see that assault by a sharp object remains the #1 cause of the mechanism of injury, with a very, very much lower proportion of firearm injuries. So those penetrating injuries cause major issues. Ngwelezan is a hospital in the northern parts of KwaZulu-Natal. And this is a tertiary center. It's a referral center for the most of northern KwaZulu-Natal. I've got a personal connection that I used to work in a referral hospital that used to refer the patients to KwaZulu-Natal, to Ngwelezan. And in this particular hospital, they again saw very high levels of interpersonal violence. And when they started looking at the costs, these patients stay on average 10 days at a time. 58% require resuscitation beds, about a third of them undergo emergency surgery, and at least 50% of the patients require blood products. This gives us an average cost of over $5,500 per patient. So that's nearly 8.3 million rand in this particular cohort. And they weren't even able to include the staffing costs, operating theatre equipment, nutrition, dressings, and all those aspects. And this is in a referral center for over 20 district hospitals with a population that is serving of 2.3 million people. So there's an incredible pressure to use up use the blood, to use trauma as a major burden on our population. And the fact of the matter is that blood is a scarce resource in South Africa. We've got a very low blood donation rate. It's nearly 10 times lower that of more developed regions. We've got 42 units a day in which to use this unit, and the SANBS has to collect around about 3,000 units per day. And particularly during our COVID lockdown, we were well aware of the pressures involved because our donations dropped dismally. And even as of today, this is taken from today, we've got limited stocks of particularly O positive and O negative blood. So we're in a constant state of flux when a single patient takes up 30 units of blood. This impacts many of the other patients within our area. And from the SANBS, we've got patients who are generally anemic. We've got 50% of patients that are deferred when they come for donation, that are deferred due to their low hemoglobin levels. Now, at the same time, we're trying to deliver more than 1 million blood products annually to 320,000 patients. These major drivers are the obstetric hemorrhages, the cytopenias associated with TB and HIV, and of course, trauma and surgery, as I've mentioned. And this is, of course, in contrast to developed countries. So if we look at the number of products issued by discipline, you will see that trauma is a small aspect, but you'll see general surgery and ICU and medical as being one of the major drivers of transfusions overall. Now, we were fortunate that we have a blood bank on site, which is staffed 24 hours. So in our case that we were dealing with the lacerated iliac vein, we had a porter that was able to go down to fetch blood within 20 minutes. We could go down, wait for the blood, and bring it back up to us whenever we need it. Unfortunately, if you look at the secondary level hospitals, there are very few places that have staffed blood banks. This particular study done by Morris, we're just looking at the Cape Town Metropole, where the majority of patients present at secondary level hospitals and are referred on to tertiary level hospitals. The 3 tertiary hospitals have 24 hours staffed blood banks. The rest of the hospitals have a very modest supply of group O positive and O negative blood for uncross-matched emergency blood. And your distance to your nearest 24-hour service They vary between 5 kilometers and 25 kilometers, depending where you are. And depending on the traffic, and if anyone lives in Cape Town, you'll know how bad the traffic is, the round trip may be between 2 and 3 hours. So the validity of actually using a massive transfusion protocol in these centers makes it very difficult. There are a number of different transfusion policies that are used across the border here in South Africa. And in this particular study, as I mentioned, record keeping is not always robust. And we've got a lot of the data on indications is not very full when you look at the cross-match form that's sent off to the blood bank. This cross-sectional study from a few years ago looked at the hospitals that I've mentioned. And what's important is that 26% of the trauma cases consumed 31% of the units, and even a high proportion when it was at the tertiary level, which in this particular case is Curtis Keith. And the trauma patients consumed a high volume of emergency blood per episode. That's the 1.9 versus the 1.3 units. And if you look at this table here, you'll see that the number of cases of gunshots, stab heart, stab chest, blunt assaults, and then the very small proportion of road traffic polytrauma resulting in the use of red blood cells. In the tertiary hospital here, you'll see again even a higher proportion of these trauma cases. What's interesting about this particular study is the very high proportion of blood usage for anemia. And this was as high as 19% of the transfusion episodes, particularly at the district hospitals. Now, I don't know whether that is because of lack of time to order blood, but it is a concern that so many patients required transfusion for anemia. What was noted in the study was that the emergency center using the most emergency blood for anemia was located furthest from the blood bank. And perhaps that reflects the concerns about access to blood when you need it, particularly after hours. Now, moving on to obstetric hemorrhage, the recent triennial report on confidential inquiries into maternal deaths in South Africa has been released, reflecting the years 2017 to 2019. And it remains obstetric hemorrhage remains one of the 4 major causes of maternal mortality in South Africa. We do know that we have got a high maternal mortality rate, and it is, as a matter of scale, much larger than first world countries. And the latest triennium, we had 516 deaths over the last 3 years from maternal hemorrhage. And 90% of these deaths were possibly or probably avoidable. And about 15% of them was purely due to a lack of blood. What is encouraging is that the institutional maternal mortality rate in South Africa has slowly been dropping since 1998. And in fact, it's the first time since 1998 that the rate has dropped less than 100 per 100,000 live births. And where this actually occurs is, or what is interesting is that 75% of these deaths now occur at level 1 and level 2 hospitals, which generally do not have blood banks on site. 43% of the postpartum hemorrhage deaths occur at level 1 hospitals, and they die quickly within 24 hours of onset of hemorrhage. In terms of the package of care, if you look at the guidelines published by the government, a district level hospital is expected to provide blood transfusions, and they only provide an emergency blood. In our context, it usually means it's O positive or O negative blood, maybe 4, maybe 6, maybe 8 units, depending on demand. And then if you need to get more, you need to send a driver to your nearest hospital or 24-hour staff blood bank with a cross-match tube, and then you can fetch more blood. And maybe you can order some emergency red blood cells. A regional level hospital is expected to have a blood bank on site. Now, from personal experience, there are various ways that, so we've talked about Westphalia Hospital and Helderberg Hospital, all within 50 to 70 kilometers of Curtis Keith. Now that's far, but then you look at a place like Manguzi Hospital, where I did my community service and some medical officer time. We're looking at about a 256 kilometer journey, at least 3.5 hours if you manage to avoid the cows. This is on relatively good roads, and there are other areas in South Africa that are just as much under pressure in terms of trying to get patients the blood they need or to the definitive care. You might ask, well, why don't we use air services? And unfortunately, the grass strip, you have to first chase the cows off it and make sure that it's safe for the plane to land. And generally speaking, you wouldn't be able to do it at night because many of the flights were not certified for night landings. So, when we're dealing with a patient who had a postpartum hemorrhage, we were fortunate that we had a senior surgeon that was able to control the hemorrhage while I applied the use of any and all possible red blood cells. I managed to get red blood cells from hospitals that are close to us, only about 50 to 100 kilometers away, and we were able to stabilize the patient and then send her down to Empangeni, to the regional hospital there. And so we were fortunate we had a good outcome. But the fact of the matter is that there are many patients that by the time they have activated a major hemorrhage or situation, it's very difficult to get the patient to the care to where they need to be. And as you can see here, we've got a slowly decreasing institutional maternal mortality rate over the last 8 years. And what's encouraging is that it's definitely on the decline. And you can see the last year, which is 2019, for which we have data, is at the lowest level it's ever been. So there is some signs that extensive training that has been given to junior doctors, the strengthening of regional expertise has made an impact. The strengthening of local referral guidelines as well as ambulance services do help. But at the same time, we've got a long way still to go. In terms of the other, I think we need to contextualize and make it rational for our situation, and which is potentially useful and something that we've been using for many years now, is the use of freeze-dried plasma within the context of massive hemorrhages. It's been developed in the 1930s, and although there was a period for about 2 decades where there were concerns about disease transmission when production was stopped, it was restarted a number of years ago. And there are about 3 manufacturers worldwide who produce freeze-dried plasma. And live plasma has been used extensively, particularly in the pre-hospital setting. So basic. Slightly unnerving, and is being used in the military settings as well. The great advantage, and where it's potentially most beneficial here in South Africa, is that it's because it has no preservatives and got a long shelf life, and it's ABO universal. It can be easily used in rural areas, and I've mentioned that as I've used it in Manguzi, it's used in many different areas within South Africa, and be able to store it below 25 degrees Celsius, which is it can be quite tricky in some places in South Africa. It's not approved by authorities in several countries like France and the US, but recently civilian use has approved the use of freeze-dried plasma in Germany, Norway, and Denmark. And looking at in the context of massive hemorrhage, there is very limited data. There's very few randomized control trials, a great deal of heterogeneity, but this recent systematic review has demonstrated a decreased time to first administration and no major difference in outcomes. But they weren't able to tease out any other differences, and because of the lack of control groups or missing data in some of the other trials. Of course, 5 of these studies were in the military, and so the applicability is limited. But what is interesting is that the only randomized control trial that was included in that systematic review looked at fresh frozen plasma directly versus lyophilized plasma. And although there was no difference in the rise in fibrinogen levels after 24 hours, the initial rise in fibrinogen favored the use of freeze-dried plasma. So in the context of where we see a lot of obstetric hemorrhage, you can see the benefits of using a product like FDP. There are a number of ongoing trials at the moment to look at the use of freeze-dried plasma, and these studies are being done in Norway, France, and the UK, and are due to wrap up in the next year or two. Now, in South Africa, there's it's fascinating looking at the literature on massive transfusions, and there's a lot written about it. Again, this is prior to the implementation of a massive transfusion protocol, and in this particular context, in Steve Beaker up in the northern parts of South Africa, 50% of the patients received a large number of units due to postpartum hemorrhage. In other specialities, stab, heart, and polytrauma proved a major role player, but none of these departments had a fixed guideline. And if you look at many of the studies, a lot of the comments are made that this is prior to implementing a massive transfusion protocol, or there is no fixed guidelines that are being used. And there are a large variety in ratios. And what was particularly interesting about this study was the lack of use of platelets. And hardly any of the patients received platelets except for one, a polytrauma case who got a classic 1:1:1 ratio. And very, very little use of cryoprecipitate. Last year, we published the South African Patient Blood Management Guidelines, which was a extensive amount of work done across many different provinces and different anesthetists. And the trauma guidelines in particular didn't come out with a fixed protocol per se. The major focus was on damage control protocols, the use of a 1:1 ratio of red cells and FFP or FDP was recommended 1:1. But again, the use of coagulation, point of care tests of coagulation to guide therapy were emphasized. But again, there's no a fixed protocol that was advocated. I think what it does stand out is that the recommendation that every institution should have a massive transfusion protocol that is regularly audited and reviewed every 2 years. The Trauma Society of South Africa has their own massive transfusion or massive hemorrhage protocol, which is on the 661 basis after initial 2 units of packed red cells. And they advocate a 1:1:1 ratio. A Stellenbosch protocol is developed by Professor Tim Hardcastle, who's now in KwaZulu-Natal, recommended the use of 2 FFP for every 4 packed red cells, and then the addition of cryoprecipitate after the 16th packed red cells. Now, I've mentioned context sensitivity being an important aspect, and this is where the obstetric massive transfusion protocol or massive bleeding protocol developed by Professor Lundgren and colleagues has got benefits. And I think what's important is, as Professor Cullen mentioned, was the early use of tranexamic acid as described and by the women trial. And if you do not have a blood bank on site, you actually just have to use what you have. And we advocate the use of freeze-dried plasma for all cases of severe obstetric hemorrhage. When you've got a blood bank on the site, then you can start considering using the use of cell saver, use of cryoprecipitate, point of care coagulation testing, if you have that available. But you have to adjust your approach according to what you actually have available and how far you are from your blood bank. At Grooterskloof, it is still a work in progress. It's been multiple revisions that have been in work since 2016. At the moment, we're looking at initial requests of 4 emergency O-negative red blood cells. If there are more than 10 total units that are expected, or that you've got initial blood loss of at least 40% of blood volume, or in fact, any patient where clinical judgment is made that such blood loss is imminent, then they advocate the activation of the massive transfusion protocol. The aim is to maintain our fibrinogen levels, treat early with tranexamic acid, individualize in transfusion support where possible. And I think what's important is the last couple of lines is that not all massively injured patients can be saved. And at some point, we need to actually make a decision as the clinicians treating the patient that any further resuscitation using red cells or other blood products would be futile. And that is a team decision that's going to take place. My last case for today, this describes a patient that we took for cesarean section a little while ago who had a probable placenta accreta with bladder involvement. This patient had a starting hemoglobin of 9.1, so really on a back foot, and we needed to start thinking about strategies, timing, and optimization. Fortunately, we have a very clear communication with the staff. We had a good plan, and so despite a massive hemorrhage, around about 7 liters estimated blood loss, we were able to limit the amount of packed red cells used because we were able to use cell salvage. We were able to use point-of-care coagulation testing using the TEG6, which gives us results within 11 to 12 minutes, and we were able to target the particular requirements of this patient. We had a very good outcome. So the last 2 slides are just really to mention that there are other options out there. There is a ongoing study of the use of Hemopure, which is bovine hemoglobin, which is being recruited at the moment and being conducted by Stellenbosch University, which is still ongoing. And then we just need to, we've got a major problem in South Africa in terms of our association with the lockdowns and alcohol and the effects on trauma. And you can see the massive effects of the lockdowns during COVID on our trauma burden, whether it was gunshots, stabbing, violent trauma, all massively decreased. And you can see the spike that occurs after June and the initiation of the post-lockdown phase. So in summary, we really have it's trying to apply our massive transfusion protocols, the massive hemorrhage protocols. It needs to be context sensitive, where you are, which hospital you are in, where your blood bank is on site or off site. What are your local referral patterns? How can you get a patient from Northern KwaZulu-Natal down to a referral center, or is it 50 kilometers, 5 kilometers, or what sort of expertise can you actually be able to do a hysterectomy on site? When can we transfer this patient? We need to create a protocol. You can't just work based on personal thoughts and feelings. An institutional blood utilization committee is able to provide guidance and compliance and to evaluate the use of blood products. We've mentioned the use of tranexamic acid many times, and it is a relatively cheap and cost-effective solution for South Africa. Cell salvage still remains something that can only be used at referral centers with available expertise. And then point-of-care coagulation testing is really useful in a center where we have it available, but of course it all depends on the availability of our laboratory testing and what you're able to get. Given that many of your district hospitals have very limited laboratory tests, and the utilization of, say, something like a TEG6 might, depending on where you are, that might be of benefit. Freeze-dried plasma certainly has a role to play within our context, and we need to be open in our communication and share local knowledge and see what works and what doesn't work. Thank you so much for your time. I really appreciate it.
Matthew, fantastic. Thank you so much for that wonderful overview and also providing a South African perspective. I think that was really useful. I'm going to quickly launch a little poll. Actually, it's going to be 2 of them. So I'd like you to just look at that. And then while you are answering, I'm going to see, or I don't see any questions in the chat box. Are there anybody with questions or comments from the floor for Matthew or for Jeannie? Jeannie, maybe can I start with you? Would you like to perhaps just comment your general impressions, things that stood out for you that might be different or not from your experience? Anything that caught your attention while you were listening?
Well, certainly we're faced with the same challenges in Canada, where we have essentially nursing stations that are, 1,000 kilometers from a red cell. And the way that we've had to address that is with helicopters. And so putting the blood on the helicopters, the fibrinogen on the helicopters, and taking the blood to those patients. So certainly we are faced with, problems with transport for completely different reasons. And we're facing the same challenges, obviously, even though we have more resources. We can't get point of care testing in all of our emergency departments with PEG or ROTEM, even though it's been around for a long time. And so, we're all facing the same thing, highlighting that every hospital needs a protocol. Well, we just did a survey of all the hospitals in Ontario, and 35% of them didn't have a protocol. So we're facing a lot of the same challenges that you're facing, even in obviously, more resources, lots of blood. We never really are short of blood.
And I think another aspect to mention is that some of these smaller hospitals also do not have laboratories on site. I remember when I was an intern, I worked in a hospital only 50 kilometers from Cape Town, but where I had to we had to wait a day to get any blood results back. So it can often be quite challenging, I think, and it's not as if those smaller hospitals don't have a high burden of trauma, as Matt pointed out. Great. So there's some questions here. I'll start with one from Deborah Vaz. What is your take on using cold storage platelets for emergency use? Don't know, Jeannie, if you've got an opinion on that, or Matt, any of you?
I have an opinion on cold platelets. There's no data to support yet that they work, they circulate, and cold platelets really should be restricted to a clinical trial setting. It's very different, say, than switching from, frozen plasma to freeze-dried plasma. The content of freeze-dried plasma, when you prepare it, looks the same as frozen plasma. It's the same thing, and they can be used interchangeably. And the fact that we have to do studies with them also makes me shake my head. But cold platelets, we have no idea if they work. But they're fortunately, Dr. Phil Spinella from the US is doing a large cardiac surgery trial called CHIPS. And hopefully over the next 3 years, he's going to answer whether or not cold platelets at least work in cardiac surgery where you have control. And it's a great study because for the first time, we're doing a trial in children and in adults at the same time. Because usually we just exclude the kids and then extrapolate, we're going to include kids in that trial.
Good, that makes a nice change.
That's brilliant. Okay, so let's just quickly go to the poll. So I asked the question, does your institution have a formal massive hemorrhage protocol? I see now that the automated autocorrect for spelling has changed a no into another form of knowing. So apologies for that. But only 39% of those attending could say yes to that. So there's certainly a need to work on these things, and I think also to work collaboratively on these things. While I'm going to get the next poll ready, I'm going to just quickly put this question on. There's an anonymous question. This has been a super interesting discussion. I'm curious to know what the presenters think of using a 4-factor PCC in their protocols. I think, Jeannie, you did say something about it. I think some people were not able to join us from the start. Maybe a comment from both of you?
Well, I can tell you what we're doing in Canada. We have many hospitals, as you said, they don't have lab testing, so they can't do a fibrinogen. They don't have a rapid turnaround time for their INR, and they can't thaw plasma. They have one tech in the blood bank that has to do everything. And so for those centers, we use PCCs and fibrinogen concentrates as a bridge to the helicopter, along with 4 red cells. They usually keep 4 O positive. We don't keep O negative because we can't use O negative. 4 O pos red cells, 2,000 of PCC, 4 grams of fibrinogen, called a helicopter is how we're using that. And then if you're so fortunate to be in a big hospital, we're still using plasma until we do those trials that tell us whether or not, they're equivalent.
Great, thanks very much. Matt, any comment from you on that?
Not particular. I think we still something that we need to discuss with Western Cape Blood Services and SANBS. I just note Anthony Beaton has made a very interesting comment about the use of drone technology for product delivery in rural areas. Now, I know that at SARSA last year, that's the South African Society of Anesthesiologists annual Congress, we had a presentation from the SANBS with demonstrating the use of drone technology to drop off packed red cells at a district hospital. But I think as you mentioned, we still need regulatory approval. So the idea is there, the execution is possible. I think the framework is being set up, and that's something that I think we can just watch the space. I think everyone's just so focused at the moment on just getting through the 3rd wave of COVID, which is, I've spent the whole day involved with the intubation team of COVID. So everyone's just focusing on getting through that before we start making plans to use drone technology. But in the future, yeah, I think that's certainly where we're going.
Yeah, absolutely. And I think it's amazing work done by the blood services in getting this wonderful drone technology up and running. But as you said, the South African Aviation regulatory body hasn't approved it yet, but it should make a big difference. Jeannie asked, Matt, is there a role for improving anemia in pregnant women with IV iron? So much cheaper than red cells. Now we on our topic, eh? That's a gift. Go for it.
Yeah, no, I think it's certainly been investigated in many other areas. It's part of the protocols in certainly in first world countries, particularly the UK, and we still need to introduce it into protocols here in South Africa. I think we're certainly seeing more and more interest in the use of intravenous iron, certainly in private practice, and they are starting to introduce it in preoperative clinics here in the tertiary centers. But how to apply it in a cost-effective manner for our patients coming from more rural areas, that's still something we need to look at. What are cheaper, more effective ways, whether it's the use of easily absorbed oral preparations, whether that's more an appropriate use of resources or something that's going to give a similar sort of effect. I think the major thing is recognizing how late some of these patients actually present. Many of our patients only present late in pregnancy, and so we only have a few weeks to improve the hemoglobin. We've got a massive burden of iron deficiency anemia in South Africa. So yeah, as I think Anthony Beaton again mentioned, the use of IV iron after massive transfusion to avoid delayed anemia. So I think that's after blood loss of cesarean section. We are hoping to start looking at the proportion of patients with anemia post cesarean section at a regional hospital here. So yeah, there's a lot of work that needs to be done, and trying to optimize maternal health is something that we need to really focus on.
Great, thank you. We are right on time for the end of our session. I just want to quickly close a few things here. See Z, thank you Z, pointing out that Rwanda is using drones for delivering blood for some time now. At the Western Cape Blood Service, we also had a look at the Rwanda type drones. but it was felt that that's probably not quite appropriate for our setting. I think it's a very different setting than ours. But yes, they've actually done some fantastic work there. And then we had the poll about, do you have point of care testing in your trauma center? Yes, no, or unsure. And of course, many people are here today from maybe from the same center. So one can't really extrapolate this data to so many centers, but at least for the attendees, 48% of the attendees have it present in their particular centers. But I think there's also opportunities there for certain. That leaves me just with a huge thank you to a few people. I want to say a big thank you, Jeannie, for making the time. What a wonderful presentation. I'm so glad we recorded it, and I hope you don't mind that we share it to the group that was here today. It's really something. Those of you who came late, I cannot recommend the first part of this session strongly enough. You've not been, for probably those who were late, fortunate to hear Matt at the end, but please go back to this lecture. Matt, wonderful again, so nicely prepared and so practical. Thank you for sharing the local experience. To Matthew Seftel for bringing Jeannie to this group today and making sure that we've got such an amazing speaker. Really.
Vernon, I would add that not only do we have to thank Jeannie for coming, but I understand it's much like it's a public holiday here in Vancouver. It's the same in Ontario. So Jeannie spent some time on a public holiday with us, which is extra special.
Wow, sure. That is really amazing. Thank you then. Special thank you to both of you. There were lots of thank yous and commendations in the chat box from many people. I'm sure you guys have seen it. Thank you to everybody who came today. A big thank you to Estelle Verburg with the help of Gerdien Kritzinger and Melanie Davids at home, at the home base, at Estelle for organizing, Melanie and Gerdien helping with some of the admin and logistics. We really appreciate that. Next week is going to be a public holiday, so we will not have a deep dive next week. But the week after is going to be, I think, really worth coming to again. We will have a number of speakers that will speak on COVID-19 and hematology. And in particular, we'll have an update from the Sisonke trial, which, as you know, was a South African trial on healthcare workers, including almost 500,000 people. And one of the major leads on that trial is Simba Takuva, who is in Seattle, but working closely with the team here. So he will be giving us feedback. You might have read the recent report, short report in the New England Journal of Medicine, of which he was the first author. He will speak at that session. Prof. Jessica Opie from UCT will speak on thrombosis in COVID. She's given one incredible lecture at one of the ECHO meetings, which will be updated for this session. And Dr. Luando Marco will talk about our own experience of COVID-19 in hematology patients. So I think it's a packed session, lots of good stuff. I really want to encourage everyone to advertise it widely. So with that, have a lovely morning, afternoon, or evening, wherever you are. And we'll see each other in 2 weeks again. Bye-bye. Don't forget to complete the registration on the link for your CPD points. It's in the chat box. Thank you, Jeannie. Thank you, Matthew. Bye-bye.